Thank you, Ajahn Shali. As we mentioned, according to agenda, they will start with the case presentation, and then we finish the first pass of treatment regimen simplification, and then followed by I will give a talk on the resistant associated substitution. Is it clinically important? We follow the first case first, so you can see this first case. As Ajahn mentions, it may be long time. The first one is hepatitis C genotype 1B and treatment naive non-serotic patient, and actually still quite young. How can we treat this patient? As we know that today when I talk about simplification, that means we will not longer use interferon-based therapy, and we try to choose the simple regimen which has less side effect, less drug-drug interaction, and also really short course. For the first case, if the patient have genotype 1B, treatment naive, non-serotic, what is the best for this patient? You can see this is a study of sofosbuvir and redipasvir, 1 pill daily, and this only 8-week treatment duration. It from the first clinical trial to see that the subgroup of patients who have a treatment naive genotype 1B and HCV viral load at the baseline less than 6 million IU per ml still able to achieve SVR over 95%. Therefore, the one I show you is the first one is from ICON study. Okay, and the 4-1 is confirmed by real world practice. So the real world also confirmed my own study that if you see patient like this patient genotype 1B viral load less than 6 million IU per ml and had no cirrhosis and never been treated, you can give them 1 pill a day, because sofosbuvir and redipasvir is a fixed dose combination in 1 pill. So once a day for 8 weeks, you achieve over 95% SVR across the study, even from clinical trial or real world experience. Do we have another agent? So what regimen that I will going to mention today? I will touch on only the currently available drug in Thailand. And tomorrow morning you can see I will talk on new drug and how we use them. So all the new drug I will keep for tomorrow plenary sessions. So Symposium or elbasvir plus gastroenterology, also fixed dose combination, 1 daily, again in genotype 1B, patient without cirrhosis. Again, you can see that among those who have minimal fibrosis, F0 to F2, you can see that 97% achieve FVR, just 8-week treatment duration with Symposium. So how about the new agent that I'm going to talk more tomorrow? This Piratvisuth and Piratvisuth, also fixed dose combination but require 3 tablets daily. Okay, this also give you that 8-week treatment regimen. In genotype 1, you achieve 99% just within treatment duration and not different from 12 weeks at all. And so that for the first case, that genotype 1. B, treatment naive non-serotic, and you can treat them 1 pill a day for 8 weeks and achieve at least 95% SVR.
So just would like to ask Ajahn about, so the patient, she was quite young. So can we start Hep C treatment now, or she can wait?
Okay, that's a good question. I think now if you look all international guidelines, we know that any HCV infected patient should be treated regardless of symptom and significance of liver disease, except in some countries like in Thailand. When we still have a budget constraint, we had to prioritization. The reason that now we want to treat even early patients, they had a few reasons. Number one, we know that although patient with minimal fibrosis has a less incident to progress to liver cancer and cirrhosis. You can see about 3% within 5 years. Compared with those who start with the bridging fibrosis or cirrhosis, they can develop liver cancer up to 30 to 40% within 5 year follow-up. So put together in the term of prevent liver disease, it not need to be urgent. You can wait. But what we gain from treatment, number one, we know that when you treat hepatitis C, you also able to reduce the another non-liver related morbidity and mortality. There are many studies, particularly in USA and Europe, when they have the large cohort follow up the patient many years, they found that hepatitis C treated patient who achieve SVR has a lower liver-related mortality and also overall mortality and also non-liver-related mortality. So number one, you reduce mortality in the future. Secondly, you can reduce the risk of some disease. Now we know that when you treat hepatitis C, they compare with the hepatitis patient who achieve treatment and comparing those who were not treated and comparing between those who achieve SVR and those who not achieve SVR. SVR is certain virological response, that means kill. They found that hepatitis C who receive treatment and achieve a certain virological response, they had the lower incidence of diabetes type 2 in the future, about 10-year follow-up. Secondly, let the lower incidence of chronic kidney disease and end-stage renal disease. Thirdly, let the lower incidence of coronary artery vascular disease. So put all together, treating hepatitis C, achieving cure, you also reduce non-liver related mortality. Number two, in the term of morbidity and mortality, you also reduce the transmission. They found that if you try to select some patient to treat, the risk of new case still going on. It's slightly declined, but not much. But if you intend to treat all patients, you will significantly decline the risk of transmission. And that means you can reduce the hepatitis C in the population. And because our disease quite different from HIV, we kill. So when kill, it kill from the disease. So that another issue. Oh, that the reason that why we treat all. If we have enough budget, but only in country like Thailand, we stratification, we try to use the one that urgently need, which I think is not right. And back to the first case, I forgot that I just mentioned that she has S antigen negative,
Yes,
but anti-HB core positive.
Yeah.
Now we know now that SIV and SBV and SCV can have interaction between the two viruses. Normally, when you have co-infections, 70% of the patient, hepatitis B will be suppressed by hepatitis C. And another 20% hepatitis B will dominate over hepatitis C, and about 10% have both active. In this patient, and we learn from DNA, when you suppress hepatitis C, you can cause hepatitis B reactivation. How common? If the patient have surface antigen positive, after cure from hepatitis C, about 10 to 40% we have hepatitis B reactivation. So therefore now, in many guidelines, it depends on, they have two ways. If you have S antigen positive and DNA still below the indication for hepatitis B treatment, we treat hepatitis C and monitor hepatitis DNA. If BDNA increase at least 1 log or form undetectable to be over 1,000 IU per ml, we start anti-HB therapy. The second strategy is give prophylaxis. That from European country, they will aggressive. If they had S antigen negative and no indication for hepatitis B treatment, they will give the prophylaxis antiviral B before you start hepatitis C therapy and until 12 weeks after the end of hepatitis C therapy, which I think is too aggressive. And for this patient, she negative S antigen, but anticore still positive. We know that the risk of reactivation does occur, but very minimum. It's less than 5%. So what I'm going to do in this case is I just monitor hepatitis B DNA. One is breakthrough, then I will add nucleoside or nucleoside analog.
Okay, thank you. So I think for our HIV patient, it should not be a problem for Hep B reactivation because all patients get tenofovir, lamivudine, or tenofovir FTC. So maybe this issue is quite less. So for the next case, it's quite complicated case from Dr. Philip. So he consulted me. So the patient, 58 years old, Caucasian male, living in Thailand, and have high BMI, normal blood pressure, and deny alcohol or smoker. And hepatitis C was known for 10 to 12 years. And he was treated with Pegriba in US in 2007. but he get it just only for 4 months only, and he cannot tolerate to pick riba, and he decided to stop it. And so just last 2 months ago, FibroScan show cap about 220, and fibrosis about 12.4, and has abnormal EKG. So the QTC 423, and with incomplete right bundle branch blocked, and creatinine is still okay for his age, and high ALT, AST, and also S antigen positive, anti-S, anti-core, all negative, all were negative. HIV were negative as well, and hepatitis C genotype 1A with detectable hepatitis C viral load, and he has a chance to check for his cardiovascular, has a normal LV function, but he has a total calcium score 121. So this means that he has a moderate vascular risk. So calcium score, this is the best marker for cardiovascular disease now. So it's more than 100. It means the patient have a moderate risk. So for this case, finally, monoinfection, previous PEG riba treatment, and with comorbidity. So what would you manage that?
How can I get my slide presentation?
Sorry.
Now we move to the second case. So this one, genotype 1A, treatment explained. Actually from FibroScan, 12.4 kilopascal, it can be advanced fibrosis, almost cirrhotic yet, because we know for sure that for cirrhosis it above 13, but 12.4 whatever is mean at least bridging fibrosis or early cirrhosis. So I will put in genotype 1A, PEG, ribavirin treatment experience, and cirrhotic with comorbid disease. So here is the regimen that you can look at for patient with compensated cirrhosis, and you look at genotype 1A. Treatment experience, you can start from lenacapavir, sulfapivir. Again, you can give them, this depends on, in some country they still allowed to give them lenacapavir, sulfapivir 1 tablet a day. But you can see that among those who have biologic failure, even small number of patients, they always have cirrhosis. So therefore, in some countries like Thailand, because we allow reimbursement treatment only once for lifetime, so we have to get the maximum. So I would recommend to add on ribavirin. So you can have 12 weeks, sulfapivir, lenacapavir plus ribavirin for 12 weeks, or if the patient have some contraindication to ribavirin, like have severe hemolysis, you can give them dual therapy for 24 weeks. Okay, and then we have another agent which might be licensed in Thailand soon, is the sulfapivir Hepatology. This also simple because it's a fixed dose combination once a day without ribavirin, achieve SVR over 94%. That's another simple regimen. We also have the soft bacteria. Again, we can give them 12 weeks with ribavirin, or give them 24 weeks without ribavirin. The last one, which quite complicated, which I will mention later in my presentation. You can see this elbasvir and gastroenterology fixed dose combination. The problem is when you see the patient, particularly genotype 1A, 1A had a higher incidence of baseline RAS mutation, which will going to be my lecture later on. What I can show you that you can see elbasvir separative once daily for 12 weeks, even genotype 1A, but no RAS. You can see that 99% achieve SVR, comparing only 58% in those who have RAS at the baseline in F5A, resistant associated variant, and later on in my talk, I will call resistant associated substitutions. Okay, so you can see that RAS in genotype 1A has significant effect on lower SVR with elbasvir and gasopivir therapy, but this can be manageable. You can see the last column. You still have 1A with RAS at the baseline, but you just add ribavirin to Sepatia and extend treatment duration from 12 weeks to 16 weeks. You see again 100% SVR. So therefore, that's why in the table, I will put like Sepatia. You have to check RAS at the baseline. If the patient have RAS, give them gasopivir, elbasvir in combination with ribavirin for 16 weeks, which will be more complicated. So you better to choose another regimen. The last thing is in some country, like in Thailand, RAS is still not commercially available. What shall we do? We know that the incidence of baseline RAS among genotype 1A is correlated with the higher viral load, higher incidence of baseline RAS. So therefore, in European country, they recommend for those who not able to do RAS testing, they recommend that if you have genotype 1A and viral load at baseline greater than 800,000 IU per mil like this patient, you should give them gasopivir, elbasvir plus ribavirin for 16 weeks. So come to this patient that they can answer to a Ajahn. That will be simple regimen, had to be soft well. That only one tablet 12 weeks. And soft ledisparvir had to be with ribavirin for 12 weeks because it has cirrhosis and treatment experience. Okay, and the last one is elbasvir Sepatia seem to be more complicated, require adding on ribavirin and extend treatment duration to 16 weeks. And these are the recommendations that are available. The one that I put in gray because it's not currently available in Thailand yet. Like if you had gicapivir and Piratvisuth, you can give them for only 12 weeks without ribavirin. But because it's not available in Thailand, I try not to trust and spare the apple for tomorrow morning. Thank you.
So just come back to the case. We go to the next case.
Oh, and the second issue why Ajahn putting on the next case, you had to, because he had comorbidity, you had to check drug interaction.
Yes.
You had, I can't tell you all because it's so many. The best way is go to the drug interaction of Liverpool. You just put the drug, the name of drug, and then show you whether they have drug interaction. But something you have to remember, like PPI, omeprazole. If you give the patient the simplest one, I said soft well for 12 weeks without ribavirin. But if the patient require PPI, you have to switch because PPI is a drug interaction to soft well. We allow to take only, it had to be lower dose than equivalent to omeprazole 20 milligrams a day, and you had to split the dose between DAA and omeprazole at least 4 hours apart and take drug with meal, so it's more complicated. So for myself, if PPI is not so essential, I stop PPI for 12 weeks.
Yeah, thank you. So we go for the next case. 38-year-old MSM, HIV positive, history of drug user, and he is currently on tenofovir FTC efavirenz with the viral load suppressed, high CD4 cell count, and high hepatitis C RNA genotype 3. He was treated with the Pegriva in 2014 and SVR achieved, but just recently he has an abnormal ALT, and we check hepatitis C again. It's detectable of hepatitis C RNA and elevated elevated liver enzyme more than 5 times, but no clinical symptom. VDL is also positive, and ultrasound has a fatty liver. So just the question, so because he has he is a MSM population, is a high risk of reinfection. So we have to think about in this population, if the patient have abnormal liver function test again, even though they were treated. So we have to check hepatitis C RNA, whether they have a reinfection or not. And also drug-to-drug interaction. So we will know more from Professor David Berger for the next section. And hepatitis C therapy option for this case. So what would you recommend? And also whether we need to do resistant testing and in terms of significance of genotype 3 with the liver fibrosis. Yes. And also so I can see.
So before giving into detail, I just answer the simplest one first. Do we need to do the RAS testing? Next session you will hear from me about drug resistant and RAS testing, but give you the answer this first because this is the genotype 3 treatment experience. We recommend to do in genotype 3, particularly look at the Y93SON because it's significant impact to the treatment regimen. So therefore, in this case, if you in the country that you can do, you should do. In the country that you not do, it's no problem in next few years because the new DAA sometimes will not require resistant testing. So before we go to this patient have genotype 3 without cirrhosis, okay, and have HIV co-infection. I will start with the most difficult one first. During the DAA therapy era, we know that genotype 3 become more difficult to treat genotype with DAA comparing with another genotype. So we'll touch on genotype 3 first, and then we'll come back later on to talk with co-infection. Let's say for you that if the patient have genotype 3 without cirrhosis, that's quite simple. You can treat them either soft veil or soft the catheter. But when the patient have cirrhosis, soft the catheter, like from this study, it no longer good. You can see that only 89% SVR with soft the catheter either for 12 weeks or 16 weeks. You might say 89% is quite good enough, but in the DAA era, any response with below than 90. They did survey among hepatologists. Some hepatologists say that anything SVR below 95 is suboptimal. So for me, go to the not too far extreme. So anything below 90 is suboptimal with DAA-based therapy. So in this patient, solve the catheter even with ribavirin and extend treatment duration to 16 weeks, still not optimal. Therefore, you look at the ASLD guideline, ISO guideline, as well as Thailand guideline. If the patient G3 cirrhosis, we recommend to treat them with solve the catheter and ribavirin for 24 weeks without study, no clinical trial. But we know that 16 weeks still not enough. So therefore, this one should not be the treatment of choice for this patient. Okay, so I go to another one. Another one is soft veil. Okay, you can see that soft veil among G3 cirrhosis, treatment naive, soft veil for 12 weeks or 24 weeks, quite good enough. But it's not good for treatment experience. You can see that the SVR below 90 again. However, we did the study, another agent called Gastroenterology and Elbasvir. You know that this agent normally not really effective against genotype 3. Therefore, you have to add sulfonylurea. So this will be triple therapy. Two, put in the fixed dose combination, Gastroenterology, Elbasvir, and add sulfonylurea. You can see that Sepatria plus SORB in G3 treatment naive, even cirrhosis. SVR of 8-week treatment is up to 93%. But recommendation still makes regimen simple, put on 12 weeks. And look at this one, okay? Even the patient with or without cirrhosis, the regimen quite good up to almost 100% SVR. With combination it down to 83%, but bear in mind that the number of the patient is really small, only 12 patients. So they look again, This by large clinical trials called CR study. Look at the soft Elbasvir Gasopivir in G3 cirrhosis. You can see that 12 weeks with or without ribavirin, you achieve almost 100% SVR. So this will be another regimen. So the first one can be soft the card ribavirin 24 weeks, or when you want to save money at shorter treatment duration in order to improve patient compliance, you can give them soft Elbasvir and Gasopivir for 12 weeks. Okay. So another one did also solve well, because in the clinical trials, remember I said that it's only 12 patients, so the SVR not good. So now did the real world study. They look at the real world in German. Look at the soft Hepatology with or without ribavirin in G3. You can see that even in cirrhotic patient, you can see the SVR is good enough. It's up to 94%, even without ribavirin. So I would say for this patient, if we don't talk about HIV, either solve well for 12 weeks or solve Gasopivir, Elbasvir for 12 weeks should be adequate. And actually the patient, he hasn't had cirrhosis yet, it's just fatty liver, so that more simple. If no cirrhosis, you can give them only 12 weeks solve and the Decatavir without ribavirin. So can be 3 regimen. So I will go to what Ajahn add on this case, that about HIV co-infection. That will be actually on my last case.
So maybe I will let you finish your talk without the case,
Okay.
because we have limited time.
Okay,
Just go.
so then I will go
Yes.
from the above and then we go. So we come to this case already, okay? This cirrhosis. So this simple regimen for treatment naive or PEG-11 experience for G3, if the patient have no cirrhosis, treatment naive, you can see you can either treat the patient with soft the Decatavir 12 weeks, soft well 12 weeks, soft Elbasvir Gasopivir 12 weeks. That's quite simple one. And if you have new drug, Decapivir and Piratvisuth, just without ribavirin and 8 weeks. Okay. If the patient treatment naive but unfortunately cirrhotic, you're still able to treat the patient with soft well for 12 weeks. Soft the Decatavir ribavirin had to be 24 weeks, or soft Elbasvir Gasopivir only 12 weeks. If the patient previously failed from PEG in the front ribavirin therapy, you can see that without cirrhosis, simple still, treatment still quite simple, same as the non-cirrhotic patient. 12 weeks either soft well or soft the card, or soft Gasopivir Elbasvir. But if the patient cirrhotic, you have to give the patient soft well 12 weeks or soft the Decatavir ribavirin 24 weeks, or soft Gasopivir Elbasvir 12 weeks. So this you can choose anyone, quite simple, without ribavirin. Okay, now we come to genotype 6. Genotype 6 become the major problem in our region because it's high prevalent in Indochina, which you don't see much in European or Caucasian country. And the other issue is that why many clinical trials, when you look at registration trial, they will have a very small number of the genotype 6 patients. Lastly, you know that genotype 6 have many sub-genotypes. IC1, IQ, whatever, so it seems to be quite heterogeneity genotype. Okay, what shall we do in this the patient with cirrhosis? You see, it's a very small number. Did look at the 25 patients who have cirrhosis in 8% and 92% treatment naive, and almost of them, 88% were Asian. You can see that with the Ledisparvir Sofosbuvir for only 12 weeks in genotype 6, you achieve SVR up to 96%. That's quite good enough. So this like soft Ledisparvir, or you call Harmony, just once a day for 12 weeks. Another one is soft Piratvisuth. It seems to be not very good for genotype 6, so this is my own study. We just published last year in ESO meeting. We look in many countries where we have a lot of genotype 6. In Singapore, Malaysia, Thailand, Vietnam, 80% of the patients were treatment experienced, and about 16% were cirrhosis. You can see that soft hepatitis only 12 weeks without ribavirin, genotype 3, you achieve about 92%. And even though those who have advanced fibrosis, either F3 or F4, which means cirrhotic, you can see SVR also 92 to 100%. Just once daily tablets of soft well for 12 weeks in Asian population. And therefore, the regimen for genotype 6 treatment experience, no cirrhosis and with cirrhosis. You can see without cirrhosis, you can keep 12 weeks either soft dyspareunia, soft hepatitis, or soft decatasphere. But with cirrhosis, you better to keep 12 weeks. And for me, in the case that you're so concerned about relapse, you can add ribavirin. And so this same. Without cirrhosis, 12 weeks without ribavirin. In cirrhosis, you can keep them 12 weeks with or without ribavirin. So we come to genotype 1 cirrhotic with chronic kidney disease stage 4 or 5 with GFR below 30. This is the important issue because you know that sulfonylurea currently still not recommended in patients with GFR below 30. So you have to find another agent which able to be used in chronic kidney disease. So the first one is gastroenterology and elbasvir in genotype 1 patient who have chronic kidney disease stage 4 or 5 with GFR below 30 called C-SUFFER study. You can see that SVR by 12 weeks without ribavirin, SVR is 97% and 93%, even though those who on or not on hemolysis. And look at the chronic kidney state, either stage 4, stage 5, also achieve really high SVR up to 100% and 93% for stage 4 and 5 respectively. And when you look at cirrhosis or non-cirrhosis, you can see that still high SVR, 94 to 100%. So now genotype 1 with chronic kidney disease, stage 4 or 5, either on or not on hemolysis, just give them elbasvir, gastroenterology once daily for 12 weeks. It's good that the patient does need to get the ribavirin. As you know that ribavirin cannot be removed by hemodialysis, so it can cause severe hemolysis. So this one simple. And this you can see the side effect is not much different than the patient with normal renal function and not much significant higher than placebo-controlled population. And most of side effects are mild and transient. And we go to recommendation for genotype 1 chronic kidney disease. You can give them elbasvir, gastroenterology 12 weeks, even they have or doesn't have cirrhosis. We come to the last for this patient, HCV co-infection, genotype 3 cirrhotic. As Ajahn Anshali mentioned at the beginning that when you have HCV co-infections, the problem is you accelerate disease progression, both HIV related and hepatitis C related. As you can see, C can go to liver cirrhosis up to 20% within 5 years, and also increase the risk of liver cancer. And that's why hepatocellular carcinoma in co-infection patient, HCV, younger than those who are mono-infected HCV. And certainly, it always become aggressive, infiltrative type. So it causes to poor prognosis. So now we look at the soft decatasphere in G3 patient with HIV co-infection. You can see randomization comparing between 8 weeks and 12 weeks. And also you can see in treatment naive and treatment experienced. Just mind you, we got drug interaction. Efavirenz is the one that hepatologists don't like because they always have drug interaction with our DA. With soft and the decatasphere, you can see that if you give the patient efavirenz, you have to increase the dose up to 90 milligram daily. The good news is BMS agreed to sell 90 milligram at the same price as 60 milligram. But if the patient receive ritonavir boosted PI, we had to reduce the dose to 30 milligram. But my personal, even that from clinical trial, I normally don't reduce the dose. Because if you look at clinical trial, all 3 patients who have relapsed or virologic failure, they receive 30 milligram dose. So for me, maybe 30 is too low, even in this combination therapy. And you can see SVR. What we learn is 12 weeks is good enough. 12 weeks is up to 98% SVR among HCV, HIV co-infected genotype 3 serotic patients. And even look at the baseline, what the color of your skin, how high, well or low, either serotic or not serotic, and either whatever antiretroviral regimen, the SVR approach over 90%. And look at the genotype. You can see some genotype really small number, but across pan-genotypic with high SVR. Actually, among hepatologists, I think you see by yourself as well. When you look SVR with DA therapy, comparing between HCV mono-infected and HCV, HIV co-infected, it seems to be that SVR is always higher in co-infected patients. It's not head-to-head comparison, but you can see that with co-infection, SVR for Hep C also approach 100%. When mono-infection, you around 95%. It's not head-to-head, but everyone agree like that. We said that maybe due to virus-to-virus interaction, make it more able to kill by DAA or either DAA in contact DAA interaction itself. And you can see whatever regimen you also achieve almost 100% kill. And look in the term of HIV, by using this SORB and the card, it not interfere with your CD4 count at all. It's stable. Okay. Therefore, conclude with the co-infection. I give you the principle. I will say that indication for hepatitis C treatment in HIV, HCV co-infected person are prioritized because they have more rapid liver disease progression. They also affect to HIV and also cause the SCC aggressive form in young age, so they are prioritized. The last one is they also have the higher list of disease transmission. Maybe you know that among HCV co-infection, they will have high HCV, and the risk of HCV transmission is about 2.4, comparing with only mono infection. Okay, so the same HCV regimen in HCV mono-infection can be used in HCV, HIV co-infection, regardless of CD4 count. Okay, except the main consideration is the drug interaction and overlapping toxicity between antiretroviral and DAA therapy. I give you some example. Software, Gastroenterology, Elbasvir cannot be given with efavirenz. Antiretroviral regimen should be stabilized and adjust to avoid drug duct. We should allow until you stabilize your regimen, because if we give the drug today and then you still change your antiretroviral regimen, some new agent might interfere with our DAA. So we better to allow infectious doctor to stabilize their antiretroviral regimen first. And if we require to switch some antiretroviral regimen, like if you want to give the patient sulfonylurea and Piratvisuth, but patient taking efavirenz, we have to allow infectious doctor to switch therapy, but should not stop. In some clinical trial, when you stop, you increase the mortality, particularly from HIV-related condition. And in the good way, this is a recommendation. If you see HCV, HIV co-infected patient, you look at the CD4 count first. If the patient still have high CD4 count above 500 and had no clinical symptom of HIV related, you better to treat Hep C first. To doing this, you can avoid drug-drug interaction, and hepatitis C require only 12-week treatment regimen. Among this high CD4 count or symptomatic, it should be okay. And then you achieve SVR approach 100%, so you can get rid of the problem of C co-infection, and then you can start antiretroviral agent. But among those who have low CD4 count or symptomatic HIV infected patient or have some OI already, you have to start antiretroviral regimen until you stabilize regimen, and then we can treat hepatitis C in order to avoid drug-drug interaction. And main consideration is check on the Google about drug-drug interaction. That for my talk. Thank you.